Welcome to KJR SummaryCast. SummaryCast provides audio summaries of KJR articles created using an in-house AI tool with editorial or author review. For full details, please refer to the original article. Welcome back to SummaryCast.
Today, we're looking at a comprehensive review article from the Korean Journal of Radiology, published in August 2026. It's titled Cerebrospinal Fluid Shunts, an updated radiologic review of devices, malfunctions, and complications.
This feels like a foundational topic. These devices are in countless patients.
They are, and they're essential for managing hydrocephalus. At a high level, they're designed to divert excess cerebrospinal fluid, or CSF, from the brain's ventricles to another body cavity. Simple concept, but the hardware and the failure modes are anything but.
Right. The symptoms of hydrocephalus are severe. Headaches, vision problems, cognitive issues. So when a shunt works, it's life-changing. But when it doesn't, it's a crisis.
Exactly. And that's where radiology is critical. This paper serves as a really nice updated field guide to the hardware, what's normal, and the many ways things can go wrong.
Okay, let's start with the hardware itself. What are the core components we'd see on imaging?
A typical system has three main parts you can see in their figure 1. There's a proximal catheter, which is the ventricular catheter that goes into the brain. Then there's a valve, often paired with a reservoir. And finally, a distal catheter that tunnels the fluid away.
And what are these made of? Visibility is key.
They're usually made of silistatic, which is a durable silicone rubber. And crucially, it's infused with a radio-opaque material like barium sulfate, so the tubing itself is designed to be visible on radiographs.
Got it. So the catheter should light up. What about the valve? That's the engine of the system, right?
Precisely. It's a one-way valve that controls the flow. Traditionally, these were fixed pressure valves, low, medium, or high, and the surgeon had to pick the right one during implantation. No adjustments later.
That sounds inflexible. People change. Pressures change.
That's the key issue, which is why programmable valves became such a big deal. They allow for non-invasive pressure adjustments using an external magnetic tool. This reduces the need for surgical revisions, which is a huge advantage.
Okay, so that's the basic setup. The paper also mentions different types of shunts based on where the fluid ends up. What's the most common destination?
By far, the most common is the ventriculoperitoneal shunt, or VPS. The distal catheter drains into the peritoneal cavity. It has a high absorption capacity and is the preferred type, especially in kids because you can leave extra length to account for growth.
Makes sense. Are there other options?
Yes, though they're usually for specific situations. There's the ventriculoatrial shunt, or VAS, which drains into the right atrium of the heart.
That sounds risky. You're draining directly into the circulatory system.
It is. The paper flags a number of potential vascular complications: thromboembolism, pulmonary hypertension, even tricuspid valve stenosis. So it's often a secondary option, maybe if a patient has had repeated VPS failures or abdominal issues.
What else?
There's the ventriculopleural shunt, draining into the pleural space around the lungs, but it has a high failure rate, over 50%, and can cause fluid buildup like hydrothorax. It's often just a temporary fix.
So VPS is the workhorse for a reason. Let's go back to the valves. You mentioned fixed versus programmable. I have to ask the obvious question for a radiology-focused audience. Magnets and MRI.
Great question. It's a major concern. The paper is clear that most programmable valves have magnetically adjustable components, and exposure to a strong magnetic field, like in a 3T MRI, can absolutely cause unintended changes in the pressure setting.
Yikes. So a patient gets a diagnostic scan and walks out with a malfunctioning shunt?
It's a known risk. However, the technology has evolved. Newer programmable valves, like the ProGav, have a locking mechanism, a sort of brake system that secures the pressure setting. They've been shown to maintain their settings even in a 3T static magnetic field.
So some are safe, some aren't. How is a radiologist supposed to know which is which just from looking at an X-ray?
That's the central challenge, and this is where the review is incredibly useful. It provides a detailed breakdown, especially in its Table 1, of the imaging characteristics of different programmable shunts. The visual appearance is the key.
Okay, walk me through a few examples.
Sure. The Codman-Hakim valve, for instance, looks like a round radio-opaque disc. The setting is indicated by a tiny radiolucent notch on the periphery of the dial.
So you need a well-positioned, clear film to even see that notch.
Yes, and you have to know what you're looking for. Then you have something like the Sophisa Polaris, which has two parallel radio-opaque squares as the dial. Its setting is indicated by another smaller radio-opaque square inside.
And Medtronic?
The Medtronic Strata valves have a very distinct shape, a circular center with squared-off margins. They also use a radiolucent notch to show the setting.
I'm noticing a pattern here. Small, subtle indicators. What about the newer ones, the ones that are more MR safe?
The Aesculap ProGav is a good example. It has a centrally round dial, but the setting is indicated by the pointed side of an internal marker. And importantly, it also incorporates a gravitational unit, which is an anti-siphon device.
Hold on. Define anti-siphon device. Why is that needed?
Siphoning is a major problem, especially with VPS shunts. When a patient stands up, gravity creates a siphon effect, pulling CSF out of the ventricles too quickly. Think of a hose siphoning gas from a tank. This causes overdrainage.
Which can lead to severe headaches and other complications.
Exactly. So anti-siphon devices are designed to counteract that. They reduce overdrainage when the patient is upright. The paper mentions several types, including diaphragms and gravitational units.
So the bottom line for the radiologist is you have to identify the specific model of the valve. That tells you its features, its MRI compatibility, and how to read its pressure setting from the image.
You nailed it, and this review is like a spotter's guide for all of that.
Okay, so that's the normal appearance. Let's pivot to the main event, malfunction and complications. The paper says these are among the most failure-prone medical devices. Quantify that for me.
The numbers are stark, especially in pediatric patients. Failure rates are 30 to 40% within the first year, and around 50% by the second year.
That's a coin flip on a 2-year survival of the device. That's rough. What is the most common reason for failure?
Mechanical obstruction, by a long shot. It accounts for over half of all shunt failures in the pediatric population. And the most common site of obstruction is the proximal catheter, the one inside the ventricle.
What blocks it?
Usually choroid plexus growing into it or debris and blood clogging the tip or the valve mechanism. The distal end can also get blocked, say, by kinking or the formation of a pseudocyst in the abdomen, which is a collection of CSF that gets walled off and can't be absorbed.
And how is that diagnosed? What are the imaging signs?
For suspected obstruction, CT is often the first choice in an acute setting. You're looking for an increase in ventricular size compared to prior scans. That comparison is absolutely essential. Ancillary findings like transependymal edema, fluid seeping into the brain tissue around the ventricles, can also be a clue. Figure 5 in the paper shows a beautiful example of this.
So a baseline post-operative scan is critical.
Incredibly so. But the paper also notes there aren't universal guidelines for routine surveillance imaging. It's almost always driven by new or worsening symptoms.
Okay, beyond obstruction, what's next on the list of failures?
Tubing fracture and disconnection. These are two distinct issues. A fracture is a break in the tubing itself, often a late complication. Disconnection is when two separate components come apart at their junction.
Where do fractures usually happen?
Most often in the neck. It's an area of high mobility, and over time, scar tissue can tether the catheter while the patient, especially a child, grows. This puts stress on the tubing, which can calcify and become brittle, and eventually it just snaps.
The imaging for that seems straightforward. A shunt series of X-rays should show the gap.
Yes, a shunt series is the most effective modality. You can see a clear gap between the fractured segments, as shown in Figure 7. The distal portion often migrates away, sometimes ending up coiled in the peritoneal cavity.
And disconnection? You said that's different.
Disconnection typically happens early after placement, often at the junction between the catheter and the reservoir or valve. It can be due to surgical error, like a poor connection, or material failure. Figure 8 has these really striking 3D volume-rendered CT images showing a proximal catheter pulling away from the valve on postoperative day 26.
And some of these connectors are radiolucent, right? So they could mimic a disconnection on a plain film.
A great point. The paper cautions about that. 3D CT reconstructions can be very helpful to distinguish a true disconnection from a radiolucent component.
What about infection? Where does that rank?
It's the second most common cause of shunt malfunction. Most infections happen within the first 6 months of implantation and are usually caused by skin flora like Staphylococcus epidermidis introduced during surgery.
What are the imaging signs of infection? Can you see it on a CT or MRI?
It can be subtle. The paper says that contrast-enhanced CT or MRI results are often not definitive. However, you might see signs of ventriculitis, like irregular ependymal enhancement along the lining of the ventricles. Figure 10 shows this quite well, with debris seen layering within the ventricles, which is a strong sign.
So, infection is more of a clinical diagnosis, but imaging can provide supporting evidence.
Exactly. Let's talk about a more subtle functional problem, overdrainage.
Right. This is where the shunt technically works, but maybe too well.
Precisely. It happens with low-pressure valves or systems without an anti-siphon device. A long-term effect of chronic overdrainage is something called slit ventricle syndrome, or SVS.
What does that look like?
The ventricles become very small, sometimes almost slit-like, as you can see in Figure 12. The paper notes it's characterized by these small ventricles and shunt patency issues.
That sounds like a diagnostic challenge. The ventricles are small, so you might not immediately suspect shunt malfunction.
It is a major challenge. It requires a high degree of clinical suspicion. This is a scenario where adjusting a programmable valve to a higher pressure setting can be therapeutic.
The paper also mentions migration. This is where parts of the shunt move to places they shouldn't be.
Yes, and it can happen at both ends. The proximal tip can migrate out of the ventricle and into the brain parenchyma. The distal tip is notorious for getting into all sorts of places. It can erode into the bowel, the bladder, the liver, or even migrate down through a patent processus vaginalis into the scrotum.
So a radiologist needs to trace the entire course of the catheter, from skull to its endpoint, on every study?
Every single time. You can't assume it's where it was on the last scan. Figure 9 shows a fascinating case of a syringoperitoneal shunt catheter tip migrating inferiorly out of the spinal syrinx and into the neck.
One last complication that stood out was metastases, tumors spreading along the shunt pathway. How common is that?
It's rare, but it's a well-documented and devastating complication. The shunt basically provides a direct conduit for neoplastic cells to travel from the central nervous system to the peritoneal cavity or bloodstream.
What kinds of tumors are most likely to do this?
Germinomas, medulloblastomas, and glioblastomas are the most common culprits. The risk is higher in pediatric patients with these malignancies, which raises really difficult clinical questions about whether to place a shunt at all in that population.
Is there an alternative?
Yes. The paper suggests that for some patients, an endoscopic third ventriculostomy could be a better option. It creates an internal bypass for CSF flow without implanting any hardware, which avoids the risk of metastasis and other hardware-related complications.
Okay, let's zoom out and try to land this. For the practicing radiologist, what are the big takeaways from this review?
I think there are three. First, know the hardware. The ability to identify the type of shunt and valve from a radiograph is no longer just academic. It has direct implications for patient safety, especially regarding MRI, and for understanding the function.
Okay, know the hardware. What's second?
Second, comparison is everything. Shunt imaging is almost meaningless without a baseline and priors. Ventricular size can be normal for one patient and pathologically enlarged for another. The trend is what matters.
Right. And the third?
Third, think about the whole system. A patient might present with abdominal pain and the cause could be a distal shunt malfunction. Another might have pulmonary symptoms from a VPLS. The shunt is a systemic implant and its complications can manifest far from the head.
And the paper underscores that imaging is usually done in response to symptoms, not on a fixed schedule. The clinical context drives the workup.
That's right. And in that context, there's a growing preference for rapid sequence MRI over CT to minimize radiation exposure, which is particularly important in pediatric patients who may need dozens of scans over their lifetime.
Bottom line, this is a complex system with numerous distinct failure modes. This review provides a really clear, updated, and image-rich framework for systematically evaluating them.
I agree. It's an elegant synthesis of a topic that touches multiple areas of radiology, a very practical guide to a very common and very challenging piece of medical technology.
A great resource for any department. That's all the time we have for this episode.
Join us next time on SummaryCast.